Good morning, everyone. I welcome you all to another edition of the Hindu Wellness series. Today's webinar on transcatheter technology for repairing heart valves without surgery is presented by Apollo Hospitals. Over the years, there have been many advances in the field of medicine. The advent of new technologies have changed the way procedures are being done. One such procedure involving one of the most complex organs of the body, the heart, is transcatheter technology for treating heart valve diseases. This may sound technical, but we have with us Dr. G. Sengotuvelu, Senior Interventional Cardiologist, Apollo Hospitals, Chennai, to break it down for us. Let me start by introducing him. Dr. Sengotuvelu is a lead interventional cardiologist of Apollo Hospitals. He is the Secretary General, Asia Pacific Society for Interventional Cardiology, Director, India Valves, and Director, Imaging and Physiology Council of India. He is recognized for his pioneering work and is a key opinion leader on complex stenting and valve interventions. He was among the earliest to introduce newer cardiac technologies into this region, such as radial procedures, bioabsorbable stents, transcatheter aortic valve replacement, transcatheter mitral valve replacement, mitral clip, and intravascular lithotripsy. He initiated the transcatheter aortic valve replacement program in Apollo Group of Hospitals and performed the first procedure in November 2015. Dr. Sengotuvelu has received a number of awards, including the Best Doctor Award from the Government of Tamil Nadu in 2019. Thank you for joining us, Doctor.
Good morning and thank you. Thank you very much. Good morning.
To start with, can you give us an overview of transcatheter technology for repairing heart valves, its evolution over the years, and its role in the treatment of heart valve diseases? Over to you, sir.
Thank you, Sarina. So it's a real pleasure and privilege to be part of this Hindu Wellness series with Apollo Hospitals. So today, the technology is advanced, and every year we have seen the growth in the technology. So the number of new technologies benefit a huge number of patients, many number of diseases can be treated in a simpler way. So transcatheter technology is one which we evolved over the years, and today it is almost near a mature phase where a number of complex heart problems are treated in a simple way. So let me share a few slides and go through the basic steps and how what is transcatheter technology and how it can benefit our patients. So transcatheter technology, repairing and replacing heart valves without surgery. So if you look at the heart disease as such, it is we commonly hear about heart attacks. So what we mean by heart attack is the heart muscles need continuous blood supply, and when there is a blood supply which is cut off due to a clot formation or blocked in the arteries, we call it as a heart attack. Heart attack is one of the most common cause of heart problems. There are a number of other diseases which can affect the heart, which more commonly can involve the valves. What do we mean by valves? Valves are present within the heart. There are 4 valves which actually help blood to flow from one portion to the other. So I will just share a small video to explain you how the valve works. So the valve, blood flows from one side direction to the other direction through these valves. So there are a number of valves, what we call the tricuspid valve, the pulmonary valve, and then the aortic valve. So the blood flows only in one direction, so that the blood cannot regurgitate or go back in the other direction, similar to how a valve works. So the flow happens in one direction, unidirection. For example, once the flow happens, the valve will close. So it doesn't allow only unidirectional flow. So the valve closes as soon as the blood crosses from the one side to the other. So that is how a valve works within the heart. So there are 4 valves. The mitral valve is on the left side. The aortic valve is another valve which is on the left side. So let me now show you a small picture where you can see this is the aortic valve, which is situated between the left side of the heart and the main vessel, what is known as the aorta, the big vessel. So the blood has to constantly go through this valve, and so that it can reach the entire body through this large blood vessel. So the aortic valve opens completely like this when the blood is pumped out of the heart, and once the blood is ejected out, the valve nicely, tightly closes. As you can see, this is a closed valve. So this is the healthy aortic valve. But some people, particularly due to aging, due to degeneration over the years, what we call it as wear and tear, the valve can slowly get thickened, what we call as degeneration, and narrowing happens gradually. It happens so gradual that often in the early period, there is no symptoms at all. So once it's very tightly narrowed, then the blood ejection becomes difficult, and hence heart muscle has to have more force, and slowly the heart muscle gets more and more thickened and has to generate more force to pump blood out of the body. And eventually, slowly, gradually, if left untreated, then the heart muscle can fail. So this is how aortic stenosis or narrowing of the aortic valve happens, which is one of the most common valve narrowing occurring particularly in elderly patients. So this is how a normal valve opens and closes, whereas a narrowed or a stenotic valve is how it looks, where it doesn't open nor it closes properly. So it can happen due to a variety of ways. As I told you, the most common is age-related degeneration, as you can see in the right side of the image. It can sometimes happen at birth when the cusp, instead of 3 cusps, which I showed you, there are only 2 cusps, which can lead to narrowing even earlier in mid 30s or 40s or even earlier. When the valve narrowing happens, the only option available till a few years was only open heart surgery, where a surgeon has to open the heart and remove the valve, the existing narrowed, diseased valve, and then put in a new valve, which is an artificial valve. There are 2 types, mechanical as well as which is now called as a bioprosthetic valve or tissue valves, which are placed, and so surgeon sutures the valve, and the person recovers gradually over a period of 2 to 4 weeks, and then the valve starts functioning again normally. But thanks to the revolution, the first procedure, what we call as transcatheter technology, where we replace the valve without open heart surgery, just like how a stent is placed, a valve is introduced through the groin and placed under the X-ray guidance, placed in the proper site, and it starts functioning normally. The first procedure was done in France by Professor Alan Crevier in 2002, but since then, a number of new developments have taken place. I was fortunate to be with Professor Alan Crevier in 2002. This was in 2002, and also later in 2019, I met him recently when he was in India. So over this period, the number of new technologies have developed, and from 2002 onwards, for the first 5 years, there was no big progress, but slowly it had taken time so much for the technology to develop. And we started our first transcatheter procedures in 2015. And since then, we have a rapid evolution. And particularly, initially, there was no approval by Indian government. So slowly, in 2016, one of the valves got approved. And subsequently, in 2016, another valve got approved. And 2018, we had Indian valve, which was indigenously manufactured valve, which we did a first in-man trial and then was approved in 2018. So now we are so much advanced that we are now able to do all the 4 valves in the heart, and we are highly advanced in making the procedure so simple. I can just give you a small overview. This is how the valve looks, and this is how it is done. A quick small animation where I can show you how the valve works. So narrowed valve is now replaced by transcatheter method. We are introducing a transcatheter valve through one of the arteries in the groin. Just like how a stent is placed, the balloon is first introduced. After balloon opening, we introduce a valve. You can see this valve is open now. This is a valve, what we call a self-expanding valve. The valve, when we remove this catheter, it opens by itself. And as you can see now, the new valve has started functioning. Similarly, we have another type of valve, what we call as balloon expandable valve. A valve is again introduced through the leg and then positioned exactly at the valve. So this is the aortic valve. We already crossed the aortic valve with the wire. And as you can see, the valve is not opening at all. So we are now introducing the new transcatheter valve. And the valve is now being taken through the big vessel, the aorta. And then crossing the narrowed valve, we position accurately. So the valve is now being positioned. And now the balloon is inflated, just like how a stent is placed. We inflate the balloon, and during that time, we pace the heart to have a rapid heart rate and gradually inflate. Now you can see that it is positioned, and the balloon is going to be inflated now. So this is done. Once we inflate the balloon, the valve is in place. So one might ask, well, how does the valve stay in place? There's a lot of calcium, which are hard particles in the valve, which helps the valve to anchor in that place so that the valve does not move from that direction. So in fact, we did our first Indian experience. We shared this experience in Indian Heart Journal, where we showed excellent results with our yearly 30 patients. This was published about 3 years ago. So to demonstrate and publish our experience. Further, we also started doing more complex valves like bicuspid valves, where by birth there are only two cusps and is more challenging to perform. We also use some filters devices so that during taking the valve in, there is not much of debris which goes into the unwanted debris which goes into the brain. So we protect the brain. And now we have moved to a less invasive TAVI. This is also we have reported in the Indian Heart Journal, where we use local anesthesia and make it more simple for the patient, as well as use minimal number of lines so the patient can go home the next day after the procedure. So further refining of the procedure has led to this minimal intervention and early discharge. So similarly, we have now advanced treatment for mitral valve, which is another valve. As you can see, there are 4 valves. The mitral valve is another valve, which is the left side of the heart. So this can be reached by small puncturing the septum, and then we place a valve in the mitral valve. This is again now becoming more and more common. This is how we do a pulmonary valve. Pulmonary valve is more commonly, it affects the children where they have disease in children, and the surgeons operate for a congenital heart block. But what happens is as they grow older, the valve is not enough for them. So once they attain a certain age, they become symptomatic. And further, new valve replacement becomes more challenging for the surgeon, as a second operation is more challenging than the first operation. So in children who have congenital heart disease, the valve, this kind of transcatheter technology helps to simplify the procedure so that the patient can go home early. So this is one of the patients who have a very tight mitral valve. You can see in this image, the valve is not at all opening at all. You can see a small opening, and this is post. We have implanted a valve, and now you can see how the valve is now fully open and allowing the blood to pass. This is a procedure, actual procedure on how we do a mitral valve. So moving on the last part of my talk, this is going to be the mitral clip, which is again when the blood leaks back from one chamber to the other, then this can be controlled without open heart surgery by clipping the leaflets. So normally, as I told you, the blood flows from one direction, flows in one chamber to the other chamber. Sometimes the valves become defective, and hence the blood leaks back. And in such situation, we use a special clip where we clip using the mitral. We are able to reduce the leak without using open heart surgery. So I will just show you a quick animation. So as you can see, the blood is leaking back. Instead of going from the upper chamber to lower chamber, the blood is leaking back, and hence we introduce a catheter, reach the valve through this catheter, and we are introducing the clip. So gradually introducing a clip and passing into the defective valve. The valve here is defective. So we position the device, the clip gradually down. And as you see, the blood is leaking back. It should go in one direction, but here the valve is defective, and hence the blue color is, you can see the blue blood coming back into the upper chamber. So the clip essentially, what it does is it just clips two damaged portion of the leaflets. So you can see we grasp it and we close the clip so that the leak is reduced. Then now you can see the back leak is reduced, and this is how a mitral clip helps in reducing valve leak without open heart surgery. So this is a real patient whom he had a severe leak back, and post the clipping, the valve leak significantly reduced, and he was able to be discharged in 2 days' time. This is an example of how a mitral clip is placed in real time. So finally, to conclude, there are fascinating new developments have taken place in interventional cardiology in the last few years and taken the treatment to great heights, so that great number of thousands of patients who have high risk for open heart surgery or sometimes who have no hope have now benefited with very less invasive procedures, which make it very simple and help the patient to be discharged early. And TAVI and technical evolution has now been considered one of the greatest innovations of modern medicine. Thank you for your patient listening.
Thank you, Doctor, for the elaborate presentation. For the benefit of our participants, can you tell us a little more about heart valve diseases? What are the causes and symptoms? And when do people need to undergo surgeries?
So the valve disease, for example, the aortic valve is one of the most common valve which gets affected. And when a person develops a heart problem or a valve disease, initially it gradually starts narrowing, and hence they may not have any kind of symptom. And for years, it might be very, very gradual progression. And once we identify it, and we can start some medicines to retard or slow down the progression of valve narrowing. As the valve narrowing achieves a certain level of severity, then they start developing symptoms, and that is when it is important to recognize and intervene. So we always tell them to keep regularly monitoring or keep checking up with the doctor, and once they have any symptom, then we need to check again. There's some tests like ECG and echocardiography, and then we start intervening and do other. When we confirm that the patient severity is high and needs further treatment, then we start the process of which is the best option, whether it is surgery or transcatheter, and then we take next steps.
Conventionally, how were valve replacement procedures or surgeries done, and how complex were these procedures?
Yeah, so the spectrum or the treatment options available for these patients who have valve narrowing initially used to be only surgical options, because you might probably ask me that when the valve, how will the valve stay? When the surgeon actually opens up, removes the defective valve, and places a new valve which is sutured into the heart. So no one ever earlier imagined that you can do such a complex surgery without opening up the heart. In fact, in even my medical school about 30 years ago, during my earlier studies, I never even thought such procedure can ever happen. But today, thanks to the modern medicine and technology, now we are able to place a heart valve and without opening the chest, and we are able to go and place it there. And because of the calcium, which is able to anchor it, so that heart valve stays in place. So basically, the surgical options are now limited, which means that this transcatheter options are now available for several patients who cannot undergo open heart surgery, because when these valves are very narrow, many of them will have associated asthma or earlier bypass surgery or age or some other problem like previous bypass surgery or even sometimes kidney disease, stroke. So when they have other problems, surgical risk becomes very high. So giving a general anesthesia and going through a major surgery. So today with this technology, we are able to do it in a simpler way by local anesthesia. We don't have to do cut open or anywhere. We do a simple procedure and they can go home within 1 or 2 days. And today, even with the next day, we are able to discharge such patients. So really, the technology is made complex procedures much more simpler.
A small message for our audience. You can post your questions in the Q&A box, and we will ask the questions to the expert at the end of the session. So you mentioned that there are certain persons who are eligible for transcatheter technology. So if I may ask, who are eligible for the technology, or if I can rephrase it, who benefits the most from transcatheter technologies?
So what we do is we have a heart team in Apollo hospitals where we have a cardiac surgeon, myself, interventional cardiologist, anesthesiologist, as well as the imaging doctors, the radiologists. We all sit together and discuss about a patient, about what would be the best options for that particular person. And that we would always tailor make. So it's not a kind of same treatment. A person comes, we do transcatheter. A person comes, we do surgical valve replacement. So what we do is we individualize the treatment based on that patient's age, that patient's symptoms, that patient's anatomy. Anatomy means the structure of the heart, how the valve is. So it is a complex decision making for each individual patient. So depending on the patient's need, for example, a person who is 75 or above 75 years or 80 years with a severe critical aortic stenosis, who has even heart blocks, then that such patient would need a transcatheter aortic valve replacement and would greatly benefit from this technology, because we can avoid a major open heart surgery in an elderly patient with multiple other risk factors. Whereas we get a 65 or a 60-year-old person who is fairly healthy, except for the valve narrowing, such patient can have the option of open heart surgery as well. So, which can be much simpler in the sense they don't have to. They don't have to, there are several other issues like the transcatheter therapy, the cost involved, the technology, which type of valve. So surgery in younger patients may be even better because of the valve. Surgical valves have been there for a longer period of time. In younger patients, we consider surgery. So what I'm trying to summarize is the person or the patient is taken into as a whole, considering not only the heart, the entire system, and taken the best possible treatment decisions for that particular patient.
Okay, sir. So what are the advantages of transcatheter technology? You mentioned that avoiding surgery is one of the biggest advantages. But other than that, sir?
Okay. So one is this transcatheter technology is much simpler. The time taken is very short. The hospital stay is quite short. They have less pain. Going through an open heart surgery always carries more pain, and there is less bleeding or blood requirement. And overall, it is there is no big scars. They don't have any scar. So overall, it is like how a stent is placed. They go to the hospital and go back home in 1 or 2 days. So it is made very simple. So that is how that is a great benefit of this procedure.
Can you tell us about the various transcatheter options, such as repair for aortic valve or mitral valve, sir?
So again, as I told you, the valves are again complex, and different valves are located in different parts of the heart. So for example, the left side of the heart has aortic and mitral valve. The right side of the heart has got tricuspid and pulmonary valve. The right side of the heart valves are more affected in younger people and during childhood. The left side of the heart, namely the aortic and the mitral valve, are some more often affected in elderly or older people. So depending on which valve has a problem, we need to appropriately access it accordingly. So for example, for reach the aortic valve, we go through the groin, the artery, and then we access it. For mitral valve, we will go through the vein, and then we go retrogradely, and we sometimes we puncture, and or sometimes depending on the valve type, we had to plan accordingly. So that is what we have to again individualize. Again, that particular patient may have multiple valve problems, so we will consider everything to decide the best options.
Do you see a lot more younger persons with the heart valve diseases now?
Yeah. So as I told you, this congenital heart disease, or the defective valve at birth, is always an issue which has been there for a long time. So these patients, when they have multiple complex issues at birth, very often surgery is considered an option in that age. And when the child strives to survive, then they need emergency surgery. And surgeon very often able to do a repair, which might not last long. For example, patients now congenital heart disease patients are living 60 or 70 years, like how a normal person can live. So when at the age of 30s or 40s, their valve, the requirement of blood, and it may not be much enough. So they need further recorrective or second surgery, for which we have these transcatheter options, which make it much more simpler in this patient. So we do see congenital heart disease significantly now coming into adulthood.
Are there any studies, like including hospital-based ones, that have laid down the success rates for the technology, whether in India or abroad?
Yeah. So every new technology goes through rigorous trials and studies, and unless we have huge amount of scientific evidence, we cannot be able to practice safely. So these transcatheter technology was essentially studied in aortic valve in a large number of trials throughout the world, and today we have huge evidence showing that it is equivalent to or non-inferior, sometimes superior to surgical aortic valve replacement. And with that background, we also have Indian studies in two way. One studies showing that the Indian valves, India-made valves, are equivalent or equal or even superior to many of the existing valves has been now proven not technology. Further, our own experience at Apollo hospitals, we have done our first. This is the only first study in India which we published the safety and efficacy of using these transcatheter valves for aortic valves. It was published in Indian Heart Journal, as I showed you. So we are highly data-driven or very scientific and evidence-based, and these studies clearly tell us that we are in the right direction.
Post-procedure, what advice do you give for patients, and what kind of follow-up do they require in terms of frequency of checkups?
So generally, we discharge the patients in a second or third day, or sometimes 3-4 days, and then they are followed up. Usually, we ask them to come after a month after discharge, and we do echocardiogram is one of these tests which are commonly done to assess the valve. So ECG and echo at 1 month, and then they come at 6 months follow-up. Usually, if they are doing well at 6 months and 1 year, regularly we follow up once a year after that. So the initial period after the valve is 1, and sometimes even at 3 months and 6 months. Beyond that is an annual review is what we generally do. And very often these patients do very well after the valve replacement.
What are the risks involved in this procedure, sir?
Any procedure, of course, carries a risk. So the whole idea of this procedure is to reduce the risk compared to open heart surgery. There is a significant reduction in risk by using transcatheter technology compared to conventional open heart surgery. But also any procedure for that matter carries a small risk, which is about 1 to 2%. Again, it depends on the individual patient, where it varies person to person.
What is the future of transcatheter technology? Where do you see this technology, say, 5 or 10 years from now?
So I think that's really interesting question. It's very fascinating because so many new developments are taking place. And today there are new different types of valves are coming. As I told you, even in our short experience, we have moved from a conventional TAVI to minimally invasive TAVI. So from a week discharge to next day discharge. So when that happens to every valve, even more complex patients can be treated. More types of devices are going to come. So more and more open heart surgeries are going to be replaced by simpler transcatheter methods. So what I'm seeing is the future is very bright with the new robotic technology, newer valve types, new technology, our experience and very trials. Definitely much more complex problems can be easily approached and treated in a simpler way.
Thank you, doctor. We will take a few questions from the audience now. What are the symptoms of valve diseases?
Okay. So as I told you in the initial phase, again, valve to valve differs. For example, we take the aortic valve. In the early part of aortic valve narrowing, there is often no symptoms, and the valve gradually worsens and narrowing becomes more and more severe. They can start developing symptoms like breathing difficulty, where they develop breathlessness on exertion, or sometimes they can even develop a chest discomfort, what we call as angina, a discomfort in the center of the chest while walking, or occasionally they can develop what we call a syncope, which means fainting or fainting spells or giddiness. So these are the three classic symptoms of aortic valve narrowing, which happens only when the valve narrowing becomes advanced. In the early part, there is often no symptoms.
One of the participants want to know, what is the life of the valves?
Okay. So we always consider the life of the valve in relation to the surgical valves, because open heart surgery has been existing for more than 3-4 decades. So the existing surgical valves has been for tissue valves has been shown to be effective for about 10 to 15 years. And today, with the transcatheter technology now having that kind of follow-up, about 10 years or so, or even more in many of the series, we find that the durability of these valves are similar to surgical tissue valves. So we have the same kind of durability of about 10 to 15 years.
What is the cost for undertaking the procedure and how much is the recovery time?
So the valve, again, as you know, any new technology, because of the research, it is initially expensive. And the transcatheter technology also similarly, since the IOT valves are expensive, but fortunately we also have the India-made valves, which have made the cost a little bit less. So the valve, the India-made valve costs around 12 lakhs at the moment. But with the improving technology and the availability of newer valve, probably the costs will further come down.
Okay, sir. One of the participants says we had done a mitral valve replacement in 2014, and she's on anticoagulant medication. Due to acetron, there are other complications we faced, such as blood clots in other parts of the body, and clearly visible over the skin. What is the correct PT-INR we need to maintain for mechanical valves? And please suggest a better way to overcome this problem.
Okay. So as I told you, the surgeons have two types of valves. One is the mechanical valve or tissue valves. Tissue valve is taken from the porcine, that is pig hearts, or from the bovine, from the cow valves. So even transcatheter valves are made more often from one of the pig heart or from the cow bovine source. But in surgery, they use mechanical valves, which means use metal, steel to make valves, mechanical valves, which last longer. But unfortunately, these bloods can clot inside the valve, unlike the tissue valve, which don't require severe blood thinners like anticoagulation, like what she mentioned, the acetron. So when they take mechanical valve, when they have a mechanical valve, surgical valve, they need to be on blood thinners. Otherwise, these valves will clot. So throughout the life, they have to be on blood thinners. Of course, it's difficult to monitor and keep the blood levels at certain level. So if you exceed the level, it might bleed. If you reduce the level, the valve might clot. So it is so important to measure, as she rightly said, to measure the prothrombin time with a blood test. By measuring the blood test, keeping the prothrombin time around 2.5, it differs. Whether there is associated other valves or associated other conditions, usually it is kept at 2.5 to 3, sometimes 2.5 very often. So we make sure that there is no risk of bleeding or the clotting. So hence it's maintained at that level in patients who have mechanical surgical valves.
We have a question from a person who has undergone balloon valvotomy twice and may require valve replacement for the mitral valve. How should he go about it?
Yeah. So the native mitral valve, which means a mitral valve which already had a balloon mitral plasty. So sometimes when you do once or twice, sometimes these valves also develop a leak. And once the leak is far advanced, they may need surgery. And today's technology for the mitral valve, which were previously operated by the surgeon, and they have a valve already in place, a new valve, transcatheter valve, can be placed over the failed previous surgical valve, which will help to anchor the valve. For a native mitral valve, where, for example, for him, where previous surgery was not done and they had two balloon procedures, then he will need a surgery. At present, mitral valve has to be operated by a surgeon, because this mitral valve, still we don't have a technology to anchor the valve in place like an aortic valve. So we will probably get it in a few years from now. There are a number of trials which are going abroad for the native mitral valve, which we will likely have it soon. But at present, we need to consider open heart surgery with mitral valve replacement for this person.
Another person underwent ASD closure in 1999, and it was closed with synthetic membrane patch. In 2013, he had mitral valve repair. Now the surgery has failed and the MR is severe. So what non-invasive options does he have for a mitral valve replacement? I think we already answered, yeah.
Yeah, so
Yes.
this person has already had two surgeries. So he has had ASD closure as well as mitral valve repair surgery. So if she has further leak, one can strongly consider doing a mitral clip procedure. So mitral clip is again, I would not call this as non-invasive. It's a minimally invasive procedure where we go through from the vein and we were able to cross from the one side of the heart to the other side, and then clip, as I showed in the animation, a clip can be placed to get hold of the two leaflets to reduce the leak, so that which can be repaired in a simpler way. So mitral clip is a definite option for this patient, but we need to evaluate depending on his age and other situation to avoid a second open heart surgery.
So for previous open heart valve replacement done in a patient, is it possible to replace the valve a second time with percutaneous procedure?
Absolutely, and this is one of the best indications for transcatheter technology. So to avoid, as we have done a number of patients we have treated who had previous surgical valves which have failed, the best option would be to consider transcatheter, which are because the previous valve helps to anchor the new transcatheter valve in whichever position, even in mitral position or pulmonary, or any valve which is previously surgically placed and failed, and to avoid a second surgery, and it makes it more simple and also gives the best possible result. So transcatheter is the first best option for a person who has failed surgical valves.
In a TAVI procedure, is the valve sutured, and what happens to the diseased valve?
Fantastic. So as I told you earlier, there are a number of calcium, one of the reasons for the native aortic valve narrowing is deposition of calcium and thickening and narrowing of the valve. So majority of patients who have degenerated aortic stenosis will have extensive calcium. So the calcium helps to anchor when we put the valve is outside of the valve has got a frame made of just like how a stent is. So these stents, when placed with a balloon expansion, or it just anchors and held very well by the calcium. It is not sutured, and the calcium essentially holds the valve in place, and it cannot move. So that is how it anchors the inside.
So the same person wants to know, like, when is bypass recommended and when is stenting recommended? Is it when the arteries are clogged heavily? Is a surgery recommended, or otherwise is a stenting recommended?
Yeah, so stenting is done for blood vessel narrowing, which supplies the blood to the heart muscle. So it's a complex decision making involving whether how many blocks are there, which part of the artery is narrowed, what is the percentage of narrowing, how is the pumping function, whether the person has diabetes, how symptomatic he is. So a number of factors help us to decide whether he would benefit from bypass surgery or a stenting procedure. So we take into account multiple factors to decide.
Are anticoagulants must for patients with replaced mechanical MVR, sir?
I think we discussed this with previous question.
Yeah.
Yes, for mechanical surgical valves, we need to be on blood anticoagulation, which are powerful blood thinners. That is one of the disadvantages of having a surgical mechanical valve, because these patients have to be on lifelong blood thinners, heavy blood thinners, which can sometimes result in bleeding elsewhere in the body. So when we use a tissue valve, either surgery or transcatheter, we can avoid using these anticoagulation, which is one of the advantages of using transcatheter technology.
A lot of participants want to know the eligibility for the transcatheter technology. So one of them, a 50-year-old, he's suffering from severe mitral valve prolapse and has been advised surgery. So he wants to know if the new technology will benefit him and will it last lifelong.
Yes. So as I told, we have to have a heart team. We will decide according to the needs of that particular patient. So for him, considering that he's only 50 and it's only a mitral valve repair, maybe we would consider, because we have to think that these tissue valves will last about 15 years or 10 to 15 years. So considering that he's only 50 years, I would probably advise him to undergo open heart surgery with a regular mitral tissue valve. Because using a mechanical valve will again result in need for heavy blood thinners. So if he has a surgical tissue valve to start with, later on for maybe 15, 20 years down the lane, if he has any issues, the transcatheter technology can be of help at that time to put in a transcatheter valve at second time. So similar to this patient, every patient has to be individualized, as I told before, to decide the best options for this treatment. So once we have a surgery, we can also do a transcatheter beyond that later on. So we can keep that in mind when we decide treatments options.
Okay, sir. Can the bicuspid valve be replaced using TAVIA?
Yes. So bicuspid valve, as I told you, aortic valve has got 3 cusps by birth. Sometimes some of them can have only 2 cusps, which is known as bicuspid valve. When they have bicuspid valve, the narrowing of the aortic valve happens earlier in life, and they might have associated problems like enlarged aorta. And now TAVI can be safely done for majority of the bicuspid valve patients, which needs again using appropriate analysis of the CT scan to decide the size and the type of the valve which will best suit for these bicuspid patients. Of course, it can be safely treated with TAVI or TAVA.
I have a question from a 77-year-old person, sir. So angioplasty was done with 2 stents in 2004, and a severe episode occurred in 2020. And it was initially mistaken for allergy, but was in fact a severe heart attack and also treated. And a coronary angiogram revealed single vessel disease with 40% ISR or proximal stent and occluded distal LAD stent. So the patient was informed that the lower half of a heart muscle was completely dead with pulmonary condition of fluid accumulation and heart pumping at 25% efficiency. She was in hospital for 3.5 months with titrated medical management. So she wants your advice on how she should go ahead.
Okay. So again, as I told you, this is exactly not only a valve problem, it is a blood vessel narrowing. So what we do in such situations is we do something called a viability assessment, whether the heart muscle is fully alive. Because when you have a heart attack, the muscle gets damaged. And they have earlier we intervene and open the blood vessel, the damage will be limited. In case probably this person had a delay and hence there is some amount of damage to the myocardium. So when we have such delay, and if the muscle is not viable, then these can be only kept on medicines and not surgery or any other angioplasty may not be helpful for that particular patient because the muscle is already damaged. So they will have to be on optimal medical therapy and followed up regularly.
Here is a question regarding can a doctor implant more than 2 stents at a single in a single surgery for blocks, and if so, is the patient's age factored in, and are the options what options are available for safety?
So generally, safety is the first primary concern when we do procedures like stenting. So the number of stents actually depends upon the length of the block and the location of the block. If a person has a long block, then they would need 2 stents. And of course, it is safe to put 2 or even more stents, provided entire blocks are completely removed. This procedure is safe and it will be effective.
In general, when you present the options to patients, how is the acceptance rate among patients?
So it is important, as I told you, if we're able to understand their issues and give them the clear options of what is available and what is the future for that options. And for example, somebody asked me, a 50-year person, how long the valve is going to last. Similar, you discuss completely with the patient. Then we are able to have their acceptance rates is very good. So it's a question of helping them to understand the available options and then take a decision along with the patient. So understanding them, and we give the best options to that particular patient.
A number of them want to know about the centers that perform transcatheter technology for heart valve replacements.
So when we started in 2015, there was hardly about 3 or 4 centers in the country. But today, the transcatheter procedures, particularly for aortic valve, has grown tremendously. In fact, we have been going around in many centers, helping them to start the transcatheter technology. For example, last week I was in Coimbatore to do a procedure in one of the main hospitals. So now there are, for example, in Coimbatore alone, there are about 4 or 5 hospitals doing transcatheter aortic valve replacement. Similarly, in every city. So in Tamil Nadu, every city now has got facilities and they have started doing transcatheter procedures. Though for the initial period, they take the help of some of the experienced operators. But I'm sure in quite a small time, we are going to have majority of hospitals will have this technology.
If the cholesterol levels are increasing gradually, what is recommended? Stenting or medical management?
Okay. See, cholesterol has got nothing to do with stenting. We don't do stenting just because cholesterol is high. Cholesterol is to prevent block formation. And people who already had a stent, we keep the cholesterol to a low level so that further new blocks do not develop. So cholesterol value again depends it is different for different people. Somebody who is at high risk, we aim to keep the cholesterol very low as possible. So it is individualized again, and cholesterol is important, particularly if you have heart disease.
Do you track patients over a period of time, and have you seen any side effects that you have not anticipated?
Yeah. So as in life, we always have to anticipate issues. We always have during the procedure, we have plan A, plan B. So we have plan C. So we always have every plan, and we sometimes when we have a problem plan, we move to the plan B. So it is always like how a normal problem is solved. Medical issues are similar. So we always plan, we have a backup, and we have the surgeon. So it's always it's like that. And we always follow patients. And particularly if you ask me, the reason for follow-up is one, we have to learn over a period from our own experience, as well as to share our experience to others. We publish and present in journals. So my experience has been clearly followed up, and every transcatheter procedure since 2015, we have a clear trans record in our laptop computers and every person and how they are doing, what type of valve was done, and all that. We have a clear follow-up, which helps for everybody. So we do that.
Do the annual preventive health checkups play a role in diagnosing heart valve diseases early, sir?
Yes, that's again very important. It is important, particularly when you reach a certain age, because we can diagnose these symptoms. As I told you, the valve narrowing is often asymptomatic in the early period. So if they come to know that they have a problem like that, then they can be more cautious, be on medication, and so that the progression is slow, and they can identify early and treat it also early. So it's advisable, particularly initial period they can have one. If the younger patients they can have once in 5 years or so, but above for 40 or 45 years, it's better to have it at least once in 2 years, or even annually if you're above 50 or 60 years.
So post procedure, what kind of lifestyle modifications are required, sir?
So a valve procedure again, we ask them to be more the lifestyle more active. So that is one of the important things. We tell them to be physically active. So depending on the person's condition, we put into a rehabilitation program to start them moving gradually to a level where they can tolerate, and being as active as possible really helps them to recover quickly. And then the diet, and then the medication, and the importance of periodic follow-up.
How was the procedure in other states or even other countries, sir?
Yeah, so the transcatheter technology was a bit delayed in our country because earlier, although the technology started in 2002, and it started in a big way in the Western countries from 2012, we were able to get it in 2015. So we were a bit, because of our approvals and availability. So definitely, mainly in Europe and in other Western countries, they're far advanced. And definitely, we are not far behind also. We are closely catching up, and we are also doing almost similar work as abroad.
There's a specific question from a person. He had a block in D2 100%, and he suffered a mild attack and was hospitalized. The doctors say the D2 being very small can't be stented, and he has been advised to take medications. What would be your advice, doctor?
Absolutely right. Who suggested the right suggestion, because with small branches, we don't have to be aggressive. It's a very, very small branch. It's like losing a small, tiny branch of a tree, which will not have major consequences. So he has to be on medications to prevent any new block formation of the major arteries. So it's important to be on medications and be on periodic follow-up to prevent new block formation.
One other question is specific to the person. I've undergone OHS for aortic valve and ascending aorta replacement in June 2018. But till this time, I have severe symptoms. So he wants to know what he should do, sir.
See, again, we have to evaluate what kind of symptoms they have and the seriousness of symptoms. Very often, they have many non-specific symptoms which are not related to the valve procedures. So if the symptoms are significant, they need to undergo evaluation with an echocardiogram or a CT scan, and then decide what is best for the particular patient.
Your closing remarks, sir?
So I would like to conclude that it was a very interesting session, and this technology is one of the greatest innovations for modern medicine, and I'm sure it is going to stay. And we are going to see far and more new technologies which are going to come up, and a number of difficult patient subsets are going to be benefited from this technology. And I'd like to thank Hindu Wellness and Apollo Hospitals and myself, on behalf of myself, to thank all the audiences for being part of this excellent webinar.
Thank you, sir. That brings us to the end of the session. I thank Dr. Sengotuvelu for sharing his views and elaborating on transcatheter technology for heart valve diseases. I hope your insights would have been beneficial for our participants. I thank all the participants for taking part in the session. Thank you, one and all. Stay healthy and stay safe.
Thank you.
Sir.